Hi, Mike Gibson, John Carroll, coming to you live from SCAI 2017. We're talking about PFOs. What's the state of the art in PFOs? I mean, it's quite a long journey to get the device through the approval process. Share a little of the journey with us, John.
Yes,
Is it traumatic to relive the journey?
No, I think it's a testament to
Persistence.
persistence, but also, we didn't really have basic pathophysiology worked out as well as in other disorders. And so, and we had the conundrum that you do have incidental PFOs in the vast majority of adults. 25% of adults have this innocent remnant of the fetal circulation. And so only in a very small subgroup is there a manifest disease process that could be related to a PFO. So I didn't think that was part of the problem. And secondly, we did have a release of 2 PFO devices early on through the HDE. And as a transient approval that then went away. But then there were ASD approved devices that could easily be used off-label. Sometimes were identical to the PFO devices. And so that's hard to have a active randomized trial when the active new therapy is kind of available down the street.
Right.
And you think of a young patient having a stroke, a 40-year-old, and they survived it, and they want to do everything possible to prevent another one. And to enter into a randomized trial is a big deal, and then if they get randomized to traditional therapy, they have a sense they're missing something, so that made it challenging.
That made it tough.
We persisted, the patients persisted in the trial, the sponsor persisted in its support, and the investigators around the US and Canada persisted, and what we got, I think, were the kind of data that not only allowed FDA approval, but also gave us better clarity of what this disease process is all about, the safety of the procedure, proper patient selection, and the fundamental need for partnership with the stroke neurology community.
Right.
Because these are stroke patients.
Yes. Yeah, that's interesting. You know, it's not just a cardiovascular problem, it's a stroke community problem. So how did you build that community?
Well, the RESPECT trial had a steering committee with 2 interventional cardiologists and 2 stroke neurologists, Jeff Safer from UCLA and David Thaler from Tufts, and then Richard Smalling from UT Houston, myself, were the interventionalists. And so right then and there, I think that's the kind of partnership, an equal partnership that's key.
Yeah.
And that should be replicated now in clinical practice. These patients need to see a neurologist, and they also need a consultation with a cardiologist.
So how are things going after the device has now been approved? I mean, how's the uptake of the procedure? Is it increasing, improving?
It certainly is increasing. And I've heard word from European physicians that the changes there are fairly dramatic based on FDA approval, and again, also based on just the scientific evidence now that there is a clear demonstration of superiority versus medical therapy alone in reducing recurrent. But a lot of those things have to happen. We have, this is a young to middle-aged population, so they're not in the Medicare, so we're not looking at CMS for a national coverage decision. We're looking at individual private insurers having to change existing policies where they said PFO closure is experimental, there are no approved devices, blah, blah, blah. That has to change. Secondly, we have to have professional societies update their practice advisories and guidelines. And that's obviously a slow process, too.
And are some ongoing trials now going on in the space?
There are, Mike, and there are 2 next week at a European stroke trial that many of us are really attuned to, the Gore Reduce trial, another secondary prevention in cryptogenic stroke patients, young middle age, that will be reported next Tuesday. And a very unique trial in that it used brain imaging to increase the event detection rate post-randomization, because you can certainly have recurrent strokes that don't reach the clinical threshold.
Right.
And that's important. Secondly, in their medical arm, it's aspirin alone versus closure with their device. There's a mix of Helix and their newer generation device, Cardioform. So perhaps that will bias the trial for higher event rates because in respect, we saw a major treatment benefit versus aspirin, less so versus people who were on warfarin.
Right.
And so that's going to be. And then Professor Moss is presenting the closed trial, which is a very important trial that hopefully will be adequately powered, but randomizes patients following cryptogenic stroke to 3 groups. PFO closure with whatever device you want to use, and there's that French and some German centers, antiplatelet therapy, and anticoagulation. So this will be the first really comparison of 2 medical treatment strategies and PFO closure. So we're all excited to learn more about the optimizing care of these patients.
Sure. I'm excited to learn more about the imaging part. You know, now that we're doing even better imaging, we're seeing a lot of people have these micro bleeds.
Yeah.
I'm sure we have a lot of micro infarcts as well. Is this a disease where it's multiple hits, or is it just one big stroke that gets you?
That's a great question because, you know, most of these patients don't have the kind of overt venothromboembolic disease of DVTs and PEs. We're talking about 2 millimeter clots that can occlude one's middle cerebral artery. And if that clot had in fact gone to the lungs, there'd be nothing.
Sure.
The filter function of the lungs would have taken care of that. So I think your question is very important of the sensitivity or methods of detecting microemboli unless they end up in a location where the clinical manifestation is huge.
Right.
It's
there may be more there than we know.
Yeah.
Yeah. Interesting. Well, thanks for leading the field, John. We're all very appreciative of this as a tribe. And thanks to all of you for joining us here live from SCAI 2017.